Hello everybody. Welcome to this Education for Health webinar today, Introduction to Spirometry in General Practice. My name is Preeti Minhas and I'm the Assistant Director of Clinical Learning at Education for Health. And I'm delighted to be joined by one of our trainers, Julie Lennon, who will be taking us through the contents of today's webinar. Julie is an advanced nurse practitioner and a Queen's nurse and an ARTP assessor. So I'm delighted that she'll be joining us today. So just before we proceed, if I can just go through a couple of housekeeping aspects. If I could ask you, if you do have a question in regards to the contents of today's webinar, if I could ask you to use the chat function and we'll come to them towards the latter end of the webinar. With over 870 of you today, if I could ask you all to keep your cameras off and your microphones on mute, that'd be great. So before we begin, I'd like to invite our Chief Executive, Dr. Linda Edwards, to welcome you all to today's webinar. Thank you.
Thank you, Preeti, and a big welcome to everybody. We're absolutely delighted to have old colleagues and new colleagues joining us for this webinar this afternoon. For those of you who are new to Education for Health, you may know that we have a long history of providing high quality education and training to healthcare professionals. And as you know, spirometry is really important. It's a diagnostic tool that many people have overlooked over time. And we here at Education for Health really understand the importance of effective spirometry for people who it directly affects. So we work closely with the ARTP to ensure that our courses are kept in line and up to date with all guidelines. We're very lucky that Julie is an assessor for the ARTP, so she's got a double role to help you here today. And just to assure you about our quality systems, we actually have a spirometry review committee that reviews all of our courses and content. They're all practicing people who are practicing, and they are overlooked by our academic board. So it has some academic rigor applied to it too, which we think ensures that we have the best quality programs available. We also offer a spirometry service design consultancy. So if anybody is interested in understanding how to set up a service locally, then please fill out the form that will be available to you at the end, along with any interest you have with other courses that we offer. So having said all of that, I think it's now time to pass over to Julie to enable you to have an interactive session and learn all the latest things about introducing spirometry into general practice. So thank you very much, Julie.
Thank you, Linda, and thank you, Preeti. And I am really excited about being here today. Welcome to the Introduction to Spirometry in General Practice. We've plenty to cover over the next hour, and we will leave time at the end for question and answer session, because I think that's really important. And Preeti will collate all the questions so that we can go through those at the end. So hopefully all your learning needs will be met. So today, what we're going to cover in the next hour is what is spirometry, why is it quality assured spirometry, and why is that so important? Different types of spirometry, what does spirometry show, the different patterns, so I'll introduce you to the patterns, and how to safely reintroduce spirometry during this post-COVID phase. And I'll talk you through the Artp certification process and the different packages that Education for Health provide to enable you to achieve that quality assurance for delivering spirometry. So let's start then with what is spirometry. It's a non-invasive test and measuring airflow and how quickly you can exhale. And we know that in pulmonary function laboratories, the inspiratory flow will also be measured along with other procedures to determine health and of course disease. Community spirometry concentrates on exhaled air, and that's what we'll be looking at today. But quality assurance spirometry can evaluate several conditions. However, the emphasis really is on quality. And it is recommended objective test to perform and identify any abnormalities in lung volumes and airflow. And that's put forward by NICE and SIGN. So why is quality assured spirometry important then? It's very important because it's at the heart of healthcare provision. In quality assured diagnostic spirometry document, it's often referred to as the QADS document, and it was published in 2013 and still has some valuable information in there. There was a recognition of people on the GP COPD registers do not meet that diagnostic criteria for COPD. This level of misdiagnosis occurs because much of the diagnostic spirometry currently performed fails to meet those essential quality standards. When used for diagnosis of disease, spirometry must be quality assured and should only be performed to an approved standard. And without this assurance, the validity of the diagnosis cannot be relied on. So what does that mean then for the patient? The potential repercussions of an incorrect diagnosis, it can have that negative impact on a patient's health and well-being. And therefore they may even be on inappropriate treatment and using inhalers that might not be appropriate for them. It has a direct burden on healthcare provision because we need to make sure that we are optimizing and managing spirometry services and making sure that the patients have been quality assured and diagnosed. And for the patient, of course, there's that pathway of missed opportunities, because if they haven't got the right diagnosis, they might be on the wrong treatment pathway. And so you can see why it's really important that we have quality assured spirometry. So the purpose of quality assured spirometry then, the ARTP produced a statement in 2020, the Statement on Pulmonary Lung Function Testing, and it incorporates procedures to ensure quality assured diagnostic investigations. And the BTS SIGN guidelines advise it is to be quality assured spirometry to demonstrate airway obstruction because it provides a baseline for assessing response to initiation of treatment and of course exclude any alternative diagnoses. GOLD also recognises that less than 6% of people have been told they have COPD, and this is likely to be under recognition and under diagnosis. So we have patients out there who don't yet know that they have a long-term condition. And GOLD confirmed post-bronchodilator spirometry is required to make the diagnosis of the persistent airflow limitation, which is what spirometry can show. So let's look at the different types of spirometry then, because there are different types that we will use in primary care. We can use the baseline spirometry or screening spirometry. So that investigates pulmonary function before a diagnosis has been established, or as part of health surveillance to protect employees' health, as put forward by the HSE. We do post-bronchodilator spirometry, that's investigative to demonstrate persistence of airflow limitation, which is seen in COPD. And we use post-bronchodilator spirometry to monitor disease and that disease trajectory. And we use that in COPD and in diagnosed asthma. And we also do something called reversibility testing. So this is to support the diagnosis of asthma according to the BTS SIGN 2019 guidelines, or indeed differentiate between different lung conditions such as asthma and COPD. But reversibility testing is rarely required for diagnosing COPD. In fact, it's used to exclude rather than to diagnose. So for diagnosing of COPD, it's post-bronchodilator spirometry, and reversibility testing is normally reserved for diagnosing of asthma. So what does spirometry show? My goodness, there's an endless list of spirometry indices. And some of you who may be interpreting spirometry will look at the spirometry report and think, oh my goodness, where can I start with this? But actually, there are really only 4 numerical values that are required to interpret spirometry in primary care. Those are forced vital capacity, the FVC. So that's the volume of lungs from full inspiration to forced maximal expiration, blowing out as fast as you possibly can. Then we've got the VC. So that's the maximal amount of air exhaled steadily from the full inspiration to maximal expiration, but it's not time dependent. And the VC is now conventionally referred to as relaxed VC, the RVC. So you'll start to see that more and more as you read spirometry reports or journals mentioning spirometry. We also have the forced expired volume in 1 second, the FEV1. So that's the volume of air expelled in that first second of the forced expiration. And that's a really important indice because it has a great affinity to the patient's trajectory of disease. But interestingly, it doesn't really tell us how well the patient is managing their disease. So if we're looking at the FEV1 in patients with COPD, it will tell us the severity of their disease, but it's not really telling us how well the patient is managing their disease. And finally, we have the ratio. So how much of the air represented by that FEV1, that amount of air in that first second, as a percentage of the whole. And we use that to determine different patterns of spirometry. So those are the 4 indices that you really need to be familiar with. And the rest really are used perhaps in secondary care and in other lung conditions. But generally speaking, in general practice, those are the 4 that we concentrate on. So spirometry in context then. Spirometry is the tool that shows a lung pattern. It is just one parameter for establishing that clinical diagnosis. So the clinical picture, such as the exposure to risk factors, people need to have been exposed to a risk factor to get COPD. And we know the main risk factor is tobacco smoke. The clinical presentation, so how is the patient presenting? And that will begin your structured clinical history. So that pattern of presenting symptoms, such as the variability or indeed limited variability. So you're ruling in, ruling out as you take that structured clinical history. The associated symptoms, such as onset of breathlessness, the chest tightness, are you thinking cardiovascular, for instance? The wheeze, the cough, and the type of cough. Is it a productive cough? Is it a nocturnal cough? Is it a cough first thing in the morning? And the nature of the sputum as well. And all this, you're beginning to build up that clinical picture so that you can then use spirometry to inform the pattern of lung function. You'll also want to explore the past medical history, including their smoking history, because that's relevant to whether you're thinking COPD or cardiovascular. Active or passive smoking is really important. The comorbidities such as CHD and diabetes. What we do know is that most patients with COPD have concomitant comorbidities linked to the same risk factors. And it's thought that airflow limitation and hyperinflation seen in COPD can affect cardiac function and gas exchange. So you can see why it's really important to take this structured clinical history. And of course, if you're looking at the atopic spectrum, you're looking at atopy and eczema as well. Always important to investigate about occupation and include hobbies in that as well. And that's relevant to asthma and that's relevant to COPD as well. And of course, the family history. We know that there is a family history often with patients with COPD, and we want to look and see if there's this expression of alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin is that protective enzyme in the airways, and if the familial disease of alpha-1 antitrypsin, patients will present with COPD type symptoms at a very early age, sometimes in their early 20s, and there will be that pattern within the family as well. So it's always worth recognizing that. And of course, looking at family history of asthma or atopy. All of this is important in order to inform your clinical decision making. So what we're going to do is look at some of the spirometry patterns, and I'll introduce you to the normal, the obstructive, the restrictive, and the combined. And I'll just give you an overview of what you would be likely to see on a spirometry report. So if we look at this normal pattern, then we've got two different graphs here. The top one is what we call the volume time graph. So you can see on the y-axis the volume of air that the patient is exhaling. And then on the x-axis, you can see the time it takes the patient to breathe out. And focusing on the volume time graph here, you can also see the measurement of air that came out from that forced blow after 1 second, and that's represented by the FEV1. So the patient would start at 0, having been appropriately prepared and explored for any contraindications, and there's a lot to go through with that before the patient starts to do their spirometry. And they would always do a relaxed blow first in order to capture the maximum amount of air in their lungs without any time attached to it, as we've just discussed. But once we've done that and we know that we've got some valuable information there with that relaxed blow, we're then going to do the forced blow. It's the forced blow that gives us our FEV1, the amount of air that comes out in that first second, and of course the ratio. So the ratio is how much of that total forced blow came out in that first second. And Gold have adopted and continued to adopt the fixed ratio. So if it's less than 70% of air comes out in that first second, then the ratio is down, so something is obstructing the air. But we can see from this graph, if you have a look, 3 litres of air came out in that first second, and the total volume is 4. So that's 3/4, 3/4 came out. So if we were to turn that into a percentage, that would be 75%. So it's above 70%, so nothing is obstructing the air here. So that would be a normal ratio. And the graph underneath is what we call the flow volume graph. And it's just an expression of the same flow, but it's looking at it from a different perspective. And what you can see at the tip of that blow is the peak flow. And that's the amount of air that's actually captured in the first 1/10 of a second. And that's why with quality assured spirometry, it's really important that the patient takes a deep breath and blasts that air out really quickly without any hesitation, because we want to capture the peak flow as well as the FEV1. And what's interesting about the flow volume graph is that it gives us a pattern. And when we look at some other patterns in a moment, you can see how that can help us with our interpretation of spirometry. So this is the obstructive pattern then. Something is obstructing the air coming out of the airways. So if we have a look at the FVC, so we can see here, there's no numbers attached to this graph because I just want to illustrate a point here. If we look at the FVC has achieved what we would expect it to achieve. But because as the patient is breathing out, perhaps because they've got COPD, or perhaps they've got suboptimally controlled asthma, but let's focus on COPD as our exemplar at the moment. The amount of air that came out in that first second, can you see, is reduced. It's a lot lower. They achieve their FVC, but it takes them a lot longer. And I'm sure in clinical practice, you've noticed this. So you'll ask a patient who might have COPD or is demonstrating an obstructive pattern, when they take that blowout, it takes them a long time. It takes them very often more than 6 seconds. It may take them 10 seconds. Indeed, if they get to 15 seconds and they're still blowing out, we invite them to stop because we don't want them to exhaust themselves. So if something is obstructing the airway, the amount of air that came out in that first second is reduced. So the ratio is going to be reduced. They're not going to get 70% out in that first second of the total volume. So that's what we refer to as an obstructive pattern. We then have something called a restrictive pattern. Now, a restrictive pattern is really a red flag. It's something that we don't really want to see with our patients. So you can see of the whole of the FVC, the patient has achieved an FVC, but it's lower because something is restricting the lungs from opening up. So they become stiff. So it could be because of fibrosed lungs, so they can't expand the lungs. So the volume of air is down because they just can't expand the lungs to get the volume of air in. But you can see the FEV1, nothing is obstructing the airway. So the ratio would be normal. And indeed, sometimes the ratio is even higher because nothing is obstructing the airway. But the FEV1 volume is down. The volume of the FVC is down, but the ratio is normal. And if we see this, we really do want to refer these patients because there could be something sinister going on. It could be something else. It could be because, I mean, not that we would be doing a spirometry with somebody who was heavily pregnant, but that could show a restrictive pattern. And sometimes gross obesity might show a restrictive pattern, but even so, it does need investigation. So we would want to know what was going on with that patient. There is another pattern that you might be familiar with, and it's called combined pattern. And sometimes it's referred to as restrictive with obstructive with superimposed restrictive. It means the same thing, but it's a combination of both. So the airways don't quite achieve FVC. They don't quite get to the volume that they used to before the airways became even more diseased. And we'll often see this pattern in patients who have severe COPD. So your spirometer might show obstruction with superimposed restriction, or it might show combined pattern, whichever monitor you're using, but they both mean the same thing. And that's often seen in patients with severe COPD. And indeed, with that pattern, with the flow volume, you'll often see what we call a church steeple. So everything is low, and instead of that lovely peak flow, everything is low, and you'll see a wee church steeple, and that shows that something serious has gone on and they've got severe lung disease. So reintroducing spirometry then. The restoration of spirometry is a key step in managing respiratory disease. We need to ensure that we've got that correct diagnosis that we talked about earlier. And therapeutic and or referral investigations need to have quality assured spirometry. And due to the COVID, provision of spirometry in primary care and community settings has been greatly reduced or indeed ceased. So this is our opportunity to consider how we now deliver services for the future. So how to safely reintroduce spirometry then? We want to look at infection control procedures. That's really important. We want to look at service parameters. So we need to identify which patients, and the ARTP and the PCRS Primary Care Respiratory Society have together put a paper and advised us of our priority patients. We need to look at the workforce, we need to look at us to make sure that we have the standards that we need, and we need to look at the equipment as well. There's a conservative estimate that we've got a lot of people waiting for spirometry, and so we need to reinstate it as soon as we possibly can. The conservative estimate of the backlog for diagnostic spirometry is in the region of 200 to 250 patients per 500,000 population. So we've got a huge backlog of patients that we need to prioritise. The ARTP and Primary Care Respiratory Society document offers this practical perspective on how safely to reintroduce diagnostic spirometry, and that's the link there for those of you who haven't yet had the opportunity to find that document. It's got some incredible information in there, and that's what's being used to inform this webinar. Consideration needs to be given to room air changes. What they are suggesting is that we need to have 6 air changes per hour in spirometry when we're providing spirometry services, appropriate PPE, infection prevention and control measures, and the cleaning of the room and equipment, and consideration for the vaccination status of staff and patients, and the use of lateral flow tests might need to be a consideration for you. So I'm going to go into that in a wee bit more detail. So spirometries need to be cleaned between patients per manufacturer's COVID-specific instructions. So it's important that you contact your manufacturer of your spirometer and ask them for their COVID-specific recommendations. All areas in contact with the patient, so that's the flow head, the spirometer orifice, so that's the turbine, all those areas should be cleaned in line with manufacturer and local infection prevention and control recommendations. All tests must be performed using a single-use antibacterial, antiviral filter. Now, I have been contacted because some nurses are saying that they don't need to use those anymore. That's certainly not the information that I've got. We should still be using antibacterial, antiviral filters, and they are different to the ones, the antibacterial filters that we were using pre-COVID. Patients with profound immune vulnerability should be considered at increased risk, and procedures to protect them should be discussed with local clinical leads. So if you do have patients who are immunocompromised and they need to have spirometry, get in touch with your IPC leads and ask them for their advice. Generally speaking, they'll be done at the beginning of the session, making sure that there are the 6 air changes between the patients receiving spirometry, and opening a window and putting a fan in the window is a consideration for you. When I do my spirometry, I do it in what we call the red room. So we have a door that's opened and I have full PPE. So what do I mean by full PPE then? So unless the patient is considered high risk, so that we'd have extra PPE and extra recommendations for those patients. We need to make sure that we wear gloves, we wear aprons, a visor, and our standard type 2 surgical masks. So that's the ones that we're all used to. Those 6 room changes of air per hour, and as I've said, extraction fans in the windows to exhaust the room air to the outdoors might be considered for you. So those are all the things that we need to make sure. So ventilation, IPC, PPE, and making sure that you have cleaned the spirometer to the manufacturer's recommendations. So for instance, we use the Clinol wipes to wipe down the surfaces between all the surfaces, everything the patient has touched. And we also use the pre-safe, peri-safe, sorry, for cleaning the turbine as well. So what happens then when the patients cough during the spirometry? Because we know that patients do. Spirometry itself is not classified as an aerosol-generated procedure, an AGP. However, spirometry cough has the potential to generate aerosol droplets, so necessitating in a mitigation strategy. And that comes this year from the CQC, and it has been said before as well. Patients are pre-counselled about actions to take if they need to cough. So try to stay on the mouthpiece if possible. Cough into the bacterial viral filter. And if patients need to cough, they should have a surgical face mask in immediate proximity. So maybe popping it under their chin, that's what we do. They drop it down to under their chin. And so placed over the mouth immediately following completion of the manoeuvre. So surgical mask lower to chin to allow mouthpiece to be used and then replaced at end of procedure, so you can offer the patient a proper surgical mask. They also talk in the document about considering using, if you know patients are going to cough and you want to mitigate the risks to you and anyone else who comes into the room and colleagues as well. One of the things that you might want to consider is doing just 1 to 2 seconds of the forced blow, because it's normally later than 2 seconds that the patient starts to cough. So if you just do 1 to 2 seconds of the forced blow, so you've got your FEV1, and before you would have done any forced blows, you would have done a minimum of 3 relaxed blows, and then you've got your capacity as well, and that's the way that you can work out your ratio. So that's something that you might want to consider. So I did talk earlier on about the priority list for spirometry, and this comes from the guidance from the ARTP. So prioritise patients for whom diagnostic spirometry will potentially impact their treatment pathway or determine their onward care, because they're a priority, aren't they? Consider spirometry for patients with a provisional diagnosis but poor response to treatment. So are you reconsidering the diagnosis? Whether you have spirometry to confirm diagnosis is valuable but not an immediate priority. And if a patient's history and clinical picture fits with the provisional diagnosis and they're responding well to the treatment, it's important to confirm the diagnosis, but not at the expense of patients in whom spirometry might alter the diagnosis or treatment pathway. So therefore, routine spirometry is of low priority as well. And I think that helps us. It almost gives us, not that we need it, but it gives us that permission to prioritise the patients, because we've got this huge backlog. We need to start somewhere. So this is what they're recommending. So reintroducing spirometry, your workforce, you and me, us, what do we need? Key to quality assured diagnostic spirometry is the establishment of a national register of certified healthcare professionals and operators. We need to be able to demonstrate to commissioners, employers and patients that we can perform and or interpret spirometry to quality assured standards, and that we have a current certificate of competence. We owe it to our patients to be able to demonstrate that. In the past, I have been given spirometry to interpret, and it has been of very poor quality. Therefore, it has not been helpful for the patient in order to help with their diagnosis, help with their monitoring, and help with their ongoing management. So we need to make sure that it's quality assured that we're using. The ARTP certification. This is a national spirometry register which ensures that all healthcare staff are recognised nationally. So it has currency. It's recognised across the whole of the United Kingdom. and it augments the clinical assessment of the patient. We've already discussed that it's that clinical assessment of the patient that leads us to which tool we're going to use, because until you've done that structured clinical history, you don't know if the breathlessness is going to be spirometry, the tool that you would use, or whether it's going to be ECG, or whether it's going to be some blood tests to look at heart failure. So this certification augments the education and training for you as competent practitioners. So there are different levels of certification. The full certificate, that's performing and reporting spirometry, and the assessment requires a portfolio, an MCQ, multiple choice question exam, and an OSCE practical exam as well. But some people might not need the full certificate. If you're not going to be interpreting, then you would just need the performing certificate, because you still need to go through that accredited education, training and assessment. But it's limited because you're not going to be interpreting. So you still need to provide your portfolio of evidence, and you still need to demonstrate that you can perform the practical spirometry, but you're not going to be interpreting. So there's the reporting certificate as well. So it used to be called the interpreting certificate. Again, you need that portfolio of evidence, and you need to complete the MCQ exam, but you don't need to do the OSCE because you're not actually performing spirometry, you're reporting on spirometry. And of course, you can do a top-up certificate as well. So if you're now working with children, so you might want to top it up for the paediatric certificate as well, or vice versa. Again, that portfolio of evidence demonstrating your level of competency and your attention to detail as well, which is what the portfolio will pick up. So the portfolio then, I've talked quite a lot about it. What does it involve? You have to provide things like background information about yourself and where you work and the number of tests that you're doing. You need to demonstrate syringe verification. We use the calibration syringe, the 3-litre calibration syringe, but what it's doing is verifying that the calibration syringe is indeed measuring 3 litres. So it's a verification procedure. You need to do a physiological control, so that's taking someone with normal lung function, and you would capture that over 10 consecutive days or 10 working days, or that there's always flexibility because you might not be working 10 days. So you might want to do over a 2 or 3 week period, and that's acceptable, that's perfectly okay. And then you have to work out what the mean value is, because that's your backup if something goes wrong with that calibration syringe. You also have to demonstrate your local infection prevention and control procedures, and within that you'll be providing a protocol to demonstrate that you are working to recommended and national guidance as well. You will also look at problems encountered during testing. So you need to demonstrate to the Artp that you would recognise a problem and what the cause of the problem was and the implication of that problem. So if that was allowed to go unrecognised, what could those implications be? And of course, you're going to provide your own patient tests that must be quality assured, repeatable, and making sure that all the indices, the ones that we spoke of right at the beginning, so the FVC, the FEV1 and the RVC are all within 150 mils, or at least the top 2 are. And don't forget the peak flow, all 3 peak flows have to be within 40 litres of each other. And that's showing that quality of that spirometry report. And then again, with the performing portfolio and with the reporting portfolio, that's the level of information that the ARTP will be required to assess in order to put you onto the register. So the MCQ examination then, it's mandatory for candidates undertaking the full and reporting and top-up certificates. You're given 20 tests, reports that may or may not include clinical information, but you will be given as much information as you need in order to interpret. You need to report on each result and select the appropriate answers in line with the provided instructions for each question, and it's under time as well. So you need to interpret 20 tests in 45 minutes. And you're timed as you start, you're timed, and then it stops after 45 minutes. But actually, that's plenty of time, so don't get anxious about it. That really is plenty of time. And it's under supervision of a nominated invigilator, because you're no longer going into a classroom where you would have an invigilator there. So the ARTP is relying on you having somebody perhaps from your workplace who sits with you as that invigilator. We've also got the OSCE examination, so that's what I'm involved in a lot. I also do the marking of the portfolios as well. But the OSCE examination, so that's mandatory for candidates undertaking the full or performing. So we want to see how you can perform spirometry. It consists of 2 sections, a practical assessment and a technical viva. So I will be sitting here, and the patient and the candidate, the students, will then instruct me how to do the spirometry. And then that's followed by a technical viva. So a number of predefined questions, and it depends whether you're on the full or the performing certificate as to the number of questions you will be invited to answer. And then once that's all done, and it's done normally under Teams or Zoom, you will then receive your result from the ARTP. And then in order to get to that stage, you need to have some education and training. So Education for Health supports the process by providing that teaching and tuition in preparation for applying for the ARTP certificate. It offers a selection of courses for healthcare professionals who are involved in delivering spirometry services, and it offers spirometry interactive blended online learning packages, including those that lead to the ARTP assessment access. It also offers spirometry refreshers, again including ARTP assessment access as well, and it offers spirometry updates. And these are all augmented by monthly tutorials. So the ARTP also provides monthly tutorials, and they're an hour long, and they are on 2 levels. So beginners to intermediate, and then intermediate to advanced. And we can go through questions that you put to us that you need answering in order to support your learning journey. So you might want to look and see which course is suitable for you, because you will decide in your workplace which one you need. So do you need the Spirometry Interactive Blended Online Learning Package? So that's for healthcare professionals responsible for performing, recording and interpreting. This one does not include access to the ARTP assessment, but the other one does, so you can have access to the ARTP assessment if that's the spirometry package that you choose from Education for Health. They also offer, as I said, the refresher, so that again includes ARTP assessment. So you may have done your training a long time ago and you've come off the register, so you need a refresher and you need then to go back onto the register. So this one would be ideal for you. And of course, there's the spirometry updates. We all embrace updates, don't we? Because there's things that are changing, like, for instance, the repeatability. The ARTP now afford 150 mils for repeatability, unless the volume of the lungs is less than 1 litre. And then, of course, it needs to be 100 mils. Because the volume of the air is smaller, but for others it's 150 mils, and that has moved on from the quads documents that was published in 2013. So updates would inform you of that. The ARTP is a wonderful site. It offers frequently asked questions. It's got a huge amount of resources, including spirometry guidelines, how to perform spirometry, how to report on spirometry, all the different components of the portfolio. You can do a mock MCQ test if you want, and I do recommend that you do that. It's really important before you go into that timed assessment that you know what you're going to be doing. So I'm now going to hand you over to Preeti, because I know in the background, whilst I've been talking, we were really keen to leave some time to answer as many questions as I possibly can before we round up.
That's great. Thank you ever so much, Julie. So yes, we do have some questions for you, and also some aspects around training right through to performing spirometry. So I'll start with the training ones first. So we have an individual who's really unclear if the ARTP is required to do a spirometry or strongly recommended.
So is the question, is it compulsory or not? I think that's behind the question. Technically, it's not compulsory. However, most commissioning groups, health boards, as we have here, most organisations would expect people performing spirometry to be quality assured, and the only way you can demonstrate that quality assurance is to have gone through a formal assessment process. So it might be mandatory for your for the role that you're in, but technically it's not statute that you must be on the ARTP register.
Brilliant. So the next question we have is, once you've entered the ARTP register, how long is it before you have to redo?
Right, well, you've got 6 months. You've got a lovely 6-month journey, and they actually give you this wonderful pathway. So you've enrolled, fantastic, welcome on board, and you'll have possibly been enrolled via Education for Health, and Preeti, you'll be able to add far more than I can with that process. But then it talks you through to sort of month 4. Let's hope you've got your portfolio in and marked, because sometimes there needs to be some changes within the portfolio, or you may not have completed the MCQ, you may not have passed. It's 80% in order to pass the MCQ, and you can take it 2 further times. And then you need to it's recommended that you have further training.
So again, it's just in line with a normal professional register, where you will have to revalidate every year, and part of that kind of requirement is that you do say that you've kept up to date with your spirometry knowledge. As with any other professional register, they do revalidate. I think it's around 5% of the population where you'll be asked to complete a set of traces. So again, if you do need further details around revalidation, etc., if you visit the ARTP website, they'll be able to provide you with all the details. I'm just going to take this question around: do we need ARTP to perform the test only, or not read results? So I think it's fair to say, like Julie said, that the completing the ARTP certification is good practice in order to perform good quality assured spirometry, and that includes every component of spirometry. If you're only involved in the reporting of the results, i.e. interpreting, then you would need to complete the interpretation certificate. Or if you're involved in every part of spirometry, then you will need to complete a full ARTP certification. So it really depends upon the role that you're undertaking in spirometry.
And Preeti, can I add to that as well? I think as healthcare professionals, it's really important that we can demonstrate that we are working to the standards expected of us from our professional bodies. You know, whether that's the NMC or whether it's the GMC, whoever it is, it's really important because if something goes wrong and there's an incorrect diagnosis, a patient is on the wrong pathway, it's important that we can demonstrate that within or that we were able to demonstrate that we worked to a high level and it wasn't through negligence that this has happened. So I think that's really important that, you know, the NMC, for instance, has its 4 Ps. That we have to comply with, and one of those is not working outside your scope of practice. And so it's really for your safeguarding that you can demonstrate, and you learn so much doing it. You know, it's a lot of work. Yes, it is a lot of work, but it's fun, and it's that sense of achievement when you've done it as well.
So probably just the last one on the training then I have, which I think probably many people have come stuck with as part of the COVID-19 pandemic. I did my course, I passed all the tests. However, I just need to complete my portfolio. Do I need to do the whole course again, or can I pick up where I left off? So do you want me to take this one, Julie?
Yeah, you would, yeah.
So in terms of that situation, we would recommend that you contact the ARTP directly. They may ask you some evidence to demonstrate that you completed the other components. They will then ask you to, I think it's a nominal amount that they will need to ask you to pay for in order to cover the OSCE, etc. But you do need to contact them directly. Just before I move on to the other questions, just in terms of the slides, if you would like a copy of today's slides, my colleagues have posted a form for you to complete. If I could ask you to complete that form, and we will arrange the slides to be sent to you. And my colleague has also confirmed that we will be issuing a certificate of attendance. So again, if you can complete that slide, that would be that would be great, because we really do want to support people in the spirometry arena. So just the last few questions for now, Julie, and just around the performing of spirometry. Is it 4 puffs of Ventolin needed for diagnosis for a post-bronchodilator spirometry COPD?
Yes, it is. Four puffs, normally a short-acting beta agonist via a spacer device. Leave 15 to 20 minutes, and when we're interpreting your spirometry, we will check, as you would check, that enough time was left in order for the bronchodilation to occur. Yeah.
Perfect. And does the transducer need cleaning between patients, or just the outer casing?
Just the outer casing, and the transducer will be cleaned at the end of the session.
There is some questions around the 6 air changes, but what I will do is I'll actually put some of them onto the slides, just so that you all have that, because there are a couple of questions around it. And again, just in terms of those puffs of a short-acting bronchodilator, we'll also post the national guidelines of where you can find that information as well. So that really does bring us to the end of today's session. We know there are a couple of questions that we haven't answered, but we will make sure that the slides cover those questions. Julie, if you can move on to the next slide for me, which you've done so beautifully. We just want to thank you all for coming to this webinar today. And we really do look forward to helping you to engage and learn and achieve in spirometry. We hope you've enjoyed today, and it's a very Yes, so thank you from all of us at Education for Health. And if you would like further information about our training courses, then please do either complete the form that we've posted in the chat function, or if you visit www.educationforhealth.org. Thank you for today.
Thank you very much, everyone.